PT school teaches us a very segregated approach to treating the body. For example, you learn how to assess and treat each joint, but not how to work with the body as a whole. The pain is hardly ever where the problem is. Listen to today's episode to learn from Jerry Hesch, a physical therapist and founder of the Hesch Institute, as he shares his whole body assessment approach and why the ankle may be the problem to jaw pain.
Hello, friends. This is Lynn Schulte, and you are listening to the Birth Healing Summit podcast. We are here for meaningful conversations that will transform the way you work with pregnant and postpartum clients. Whether it is a new perspective, tool, or technique, you'll be able to implement it into your practice today. I invite you to sit back, listen with an open mind, and grab the golden nugget today's guest has to offer. Now let's get started. Welcome, everybody. And today in this episode, we are so blessed to have with us Jerry Hesch. Jerry is a physical therapist. He is the owner or developer of the Hesch Institute, been treating for many decades and has really developed a beautiful body of work in not only just the pelvis. You started in the pelvis, right, Jerry? And then now you've added a whole body approach to your body of work, right?
Yes,
Well, welcome to this podcast, Jerry. And today we're going to be discussing this whole body approach that, we're more than just the pelvis or just a joint. And so what do you have to say? How did you first discover this?
Well, I'll precede that by saying that I've always been about the whole person.
Yes.
I've always been about the biopsychosocial aspect, learned about Engel's work in 1979. And, I do post some informative videos, and sometimes they're on a novel biomechanical concept, which I get excited about, and certainly get a lot of flack on social media. When you're not doing pain approach, you're not doing this, you're not doing that. I'm like, it's a video about a novel biomechanical concept. Your patient might have that one of these days, and you can effectively treat it. That's basically where I'm coming from. I started out as being a very active middle child in a large, loving, fighting Irish German Catholic family. I have middle child syndrome. It is what it is. I was a state wrestling champion. Had a few injuries in my childhood. But the big injury, I was a state wrestling champion and my senior year, and within 3 months had a horrific motorcycle wreck. And it was a whole body phenomenon. It was a concussion. It was neck trauma. It was being gored in the inguinal area with the handlebar, yada, yada, yada. Okay. So, and then within 2 years, a gymnastics coach looked away while I was performing something I'd never done, and I fell 5 feet on my head. So, looking back in time, and then a few car wrecks since then. So yes.
Your body's been through a lot.
Yeah, I had to develop self-treatment. I have had some necessary surgeries, but I have had to treat myself. And the most recent book chapter from 2 years ago is on the upper cervical spine, and I had to learn how to treat the atlantoaxial joint in the sagittal plane because it has very weird mechanics. So I did that. But going back in time, when I was 16, I learned about Rolfing. I was in Santa Fe. I guess Santa Fe, Sedona, San Francisco, they're all woo-woo towns. So I was in woo-woo town. Was part of a hippie co-op selling jewelry I made in downtown Santa Fe. So those were interesting times. I didn't say fun. I said interesting. So I go through the Rolfing thing, and I'm kind of enamored with that, And but I went back and I said, I still hurt between the shoulder blade. And it was my first experience of being really discounted by a healthcare practitioner. And his words were something to the effect of, I already treated that. And from there I learned, well, if you're a healthcare practitioner and you don't have what the person needs, don't you need to refer? And so ultimately, I went home and I said, well, I'm going to see what I can do. So I laid on a softball and I found that rib joint that was stuck and painful. And I learned three things. I learned number one, a fulcrum, which in that case was a softball. Number two, it helps to understand the anatomy, but you can intuitively choose the correct angle. Okay.
Okay.
And
Yeah.
then counter to any other approach to articular joint mechanics was a long duration. And I think I laid on that somewhere between 3 minutes and 5 minutes. And that then became the basis for my work.
Okay.
So
Yeah.
I use those principles throughout the body. Now, there is an occasion when I will do some oscillation,
Hmm.
but it's not real common. But when I do, it's 30 reps.
Ah, not
Okay.
one or two.
Right. Not a couple jiggle jiggle,
Yeah.
you know. So then I was in Montana. My first job was with Richard Dontigny, who was the prevailing sacroiliac joint expert back in 1981. And at night, I would go for a swim. And then I would go to the library. They had a remarkable library. They had all these journals. They had Spine Journal, Journal of Orthopedic Sports PT, which that was the first year it came out was 79, or was it 81? Might have been 81. Journal of Biomechanics. I dug deeply in the ergonomic literature. I just love learning. And I read that the sacroiliac joint was like a shock absorber. And Don Tigny's method did not acknowledge that in the manner of evaluation. Well, it took me a long time to understand his concepts. The joint is complex and the theory of it and all that is complex. So we now have, every 3 years, we have a World Congress on that subject matter. There's also a surgical conference annually now. Anyway, so I read the sacroiliac joint functions like a shock absorber. So I thought, oh, well, when I test the shock absorber on my car, I push the fender down until it stops moving. So I've taken up the slack, just like as is taught in orthopedic manual physical therapy. And then you do a spring, but the tradition lets go of the force at that time. But
Hmm.
when I test my shock absorber, I want to feel the bounce back, the recoil. So I started doing spring tests to the pelvis and have a large number of them. Some are basic for typical presentations. And if, treating that doesn't work, then I do some more advanced ones. In 87, Richard, who taught for Stanley Paris, he's in Atlanta. His name escapes me.
Sorry, can't help you out there.
Yeah, it'll come to me.
Okay.
Not, I'm struggling with his name, so I'll come back to that. But
Okay.
he published on some spring tests, and my tests are different from his, but he did publish that in a book on orthopedic PT. So for any joint in the body and even other structures, ligament and bone, even, I take up the slack in the structure and then I spring it, but keep enough pressure against that such that I will feel the recoil. And that's really informative, especially in presentations of hypermobility.
Yes.
Speaking of hypermobility, I also learned that I can easily fool myself with my magic spring tests, right? They're not perfect, okay? In a person who truly has hypermobility syndrome or Ehlers-Danlos syndrome, I have to take up the slack for a much longer period of time because there's so much elasticity that it just takes a while to unwind and take up all of the slack.
Yeah.
So I was getting false negatives with this population. Now,
Absolutely.
Yeah, an unknown for both clinicians and clients or patients, or meaning just people who have pain, who have hypermobility syndrome or EDS, is a false belief that is very damaging. And
Mm.
I have been trying to counter it for quite some time now. And that is, it goes like this. I have hypermobility syndrome. I slipped and fell on the ice. Now my, pick any joint of the body, but
Yeah.
will grab my sacroiliac, because that I followed a lot of that support group for a period of time on Facebook. So now I'm unstable.
Mm.
That's what they believe. Now I see these folks and I treat these folks, and guess what? It doesn't make them unstable.
Mm.
Okay. Of course, yes, they could play soccer and tear their ACL. I get that. But the typical day-to-day outpatient orthopedic rehab clients who come in with hypermobility, with injuries, actually have, guess what? A loss of micro motion.
Mm. That's what I
You
find.
know,
We have to
yeah,
get to that end range and really kind of appreciate the end range of movement in our clients in hypermobility.
exactly. And you can't test micro motion with gross movement tests.
No. Yeah.
Can't be done.
Yeah.
You literally have to do the test as I described it. And so anyway, being enamored with the pelvis and the SI joint, and I knew I had an SI injury, and so had to develop my own treatments for that as well.
Mhm.
But this work became whole body. I injured several parts of my body. You know,
So basically your injuries in your body has really guided and informed you in how to work with the body. I I tell you, I think that us as therapists having these issues, injuries, whatever we want to call it in our body, really can inform how we approach other people's bodies. And us
I
having that
will
experience is so
absolutely,
key. So key.
absolutely. I
Yeah.
will go see a therapist that had a similar injury. You know,
Yes.
absolutely. I've
Yeah.
fired a couple of them. Uh,
Yeah.
honestly. But
Yeah.
yeah, so my work became whole body. And is there objectivity to it? Yes, there are some studies. There are some unpublished studies. Um, in my clinic, I see people with chronic pain. The average length of time that they have hurt varies between 1 year to many years.
Yeah.
That's the population I attract. I rarely get an acute one, but I love it when I do. I'm like, give me some more of those, you know?
Right.
But
So much
so
easier.
I know when I'm being effective with them. I don't say come back 12 times. I need to know within one or two and a maximum of 3 visits, am I helping?
Right.
And I strive to give them everything that I can, because many of these people fly in from far away. This year
Mhm.
we had a person from Romania.
Whoa.
Noteworthy, I had two people from Romania in the past couple of years, and I put them together. They came from the same cities. So there's
Wow.
a
Yes. That's a
interesting
connection. Yeah.
statistical.
Yeah. So Jerry, what is your whole body approach?
Oh,
How
well,
do you
let me back
best?
it up.
Sure.
I was headed somewhere, and I have people who have studied my work, who have been certified in all of 4 or 5 different manual therapy paradigms. I'm not going to name them, but they went through rigorous training and got certified, and they love my approach.
Well, I do too, because it's
Thank
way
you.
more simplistic
It
than,
is.
yes, right? And that's like that whole SI join, is it right on right, left on left? Like your approach, you transformed my work when I took your course back in 1993, 94, somewhere in
Yeah.
there.
Yeah.
And just like, oh my gosh, you mean I can mobilize one direction, and if it doesn't move the same in the other side, then I need to treat that by doing the same mobilization in which I tested it? Like that
Nice.
was
Yeah, the
So,
language is confusing. Every time, if you told me today, I'm treating a left on right rotation of the sacrum on the oblique, I'm like, what?
yeah, right. Makes
What?
my brain hurt just
Yeah,
thinking
yeah,
about it,
every time,
trying to
every
figure it
time.
out.
So a
Right?
simple language and a simple approach is what's relevant. And then letting the body speak for itself, as Gregory Grieve eloquently said in 1983 in his enormous book that I did read. Um, we have to let the body reveal itself to us. And my gosh, I've made discoveries through several regions of the body, and then I have to go dig deep in the anatomical literature. I dig in the traditional manual therapy literature. It's not there. I dig in the anthropological literature and get support from that. So yes, forgive me, Facebook people who have a great dislike for biomechanics because pain is only in the brain, yada, yada, yeah. Forgive me, but I lost my train of thought. But there are discoveries, yes, there are discoveries being made in biomechanics, and I am privileged to be a part thereof. And I cannot grace you with a double-blinded study, a
Yes.
meta-analysis of this one case study. I'm sorry, I'm not, I am who
Yeah.
I am. I have challenges. I have limited energy to put in different directions. So I'm sorry I can't bestow that upon
Right.
you. But if you'll let me shadow you, I'll kind of watch what you do, and I might have some questions.
Right. Yeah.
All right?
I
We
just,
all need
yeah.
humility.
Yes. Amen.
There's
Amen to
little that
that.
physical therapists do that has absolute research support. We need
There's
humility.
there's very little that PTs do that have research support. Is that what you just said?
That, that is correct.
I love that. And I
It's
just,
just a fact.
yeah,
So
well,
you can watch every nuance of what someone's doing and say, where's the support for that? Where's the support for that? You
yeah,
know,
yeah,
and we can biopsychosocial anything.
yeah,
You can do that to anything. And so, we have to be careful of what we fit into that.
yeah.
We can give a little literature build up to anything, but when it works, then I'm impressed. And I'll give you one example. An 81-year-old man had a 60-year history of headache, having struck his head in a river that he used to dive into. I guess some of the silt was taken away and exposed to a harder area, or the water changed, whatever. Anyway, same spot he's dove in, since he was a teenager, since earlier as a child, and he struck his head. So I found an oblique restriction in his occipito-atlantal joint that's not just reported in the literature.
Mm,
I developed an evaluation of treatment for that, and I treated him once, and my follow-up was 5 years, and he's been headache free.
wow.
Then I found anthropologic and anatomical support. And, one could say, well, wait a minute, the occiput flexes and extends, but it also rotates one way and side bends the other. That's an oblique movement. I go, no, 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 no. When I do, passive motion testing for rotation and side bending, that movement is there. This is a different axis.
Mm,
So it's not the same thing. But anyway, so I explored the whole body and took from the tradition and also added to the tradition. And the bottom line is that I want to help people in 3 visits or less, and I want to teach clinicians to do the same thing.
so what is that approach? How do you approach the whole body? Where do you know where to work?
Well, forgive me, I'm privileged to choose my hours. No one tells me how to practice.
Yay.
I
Yes.
don't have a boss telling me what my productivity
Needs to
needs
be.
to be.
Yeah.
Okay.
Yeah.
So I'm not going to get wealthy with my model of practice. Um, but typical clinicians can dedicate a small part of their limited time to doing a whole body approach. They just have to do it a little differently than I do. But I start at the big toe. And I basically screen every major joint in the body, and I do it in perhaps 15 minutes.
Okay.
And I will create a video of how I do that quite soon. And then I know what areas I want to focus on.
Okay.
Okay. So I do that micro motion testing.
Hmm.
Uh, does that help?
Yeah. So then you're really screening every single major joint in the body to find out
Right.
where it's not moving and where it should be moving, correct?
Right. Right. And
Yeah.
it can be very simple. You know, the clavicle moves in multiple ways, as does the scapula, but I do a very nice oblique spring capturing the acromion and the humerus. There are so many people walking around with compressed AC joints, and they do all the strengthening with the TheraBand and get nowhere.
Yeah.
They get all the massage for the tight pecs, get nowhere, because it's neurologically driven. You cannot win over Mother Nature. You
Right.
can't overwhelm a reflex.
And so how do you address that reflex then?
You restore something called micromotion.
In
You
the joint.
restore, you restore the ability to spring that joint.
Okay. Well,
Spring recoil.
Jerry, I have to say your class that I took back in 94, whenever it was,
Yeah.
really did transform the way I approach the body. And I remember you talking about just compressing that bones meant to compress, bones meant to have a little give to it.
True, true.
And I just take that and I don't get as technical as you do in the exact motions and everything that I'm
Sure,
doing. I
sure.
just compress joints, compress bones, and if it moves on the left side, it should move like that on the right side. And when it
Exactly.
doesn't, then I get curious and I figure out what that needs in order to feel like the other side.
Right, exactly. And everybody's different. So you find out that person's norm.
Yes. And then, like you're saying that jammed up clavicle, I just do that same kind of motion and I feel the compression. So not only do I find the restriction, but then I allow the body to take me where it wants to go,
Good thing. Yeah.
which is usually more into the pattern.
Right, right.
And then it
Yes.
just releases and melts and expands
Right, right.
back out.
Yeah. And you're an indirect practitioner. I am primarily a direct, but
Correct.
I
Yeah.
can switch gears, but I start out direct. Yes.
Yeah, but I am loading the tissue. I'm loading the joint, which is more direct. But then once I load it, I let
Right,
the,
right,
the tissues guide me and the body guide me. And so
right. And that's easily explained neurophysiologically as well. Both approaches can be explained neurophysiologically. We're both working with receptors. Yes.
yeah.
Yeah.
And it's just, I have to say, it's a much more simplistic approach. It gives you way more information than, having to do all the range of motions and all that kind of
Yep.
stuff.
Yep.
Do you still do range of motion as an assessment for your clients or not
Um,
so much?
a little bit. Like
Yeah.
straight leg raising is only to inform me of the status of the nervous system and
Mm,
discern if that's malleable.
okay.
Okay. Um, but my hands inform me a lot more so than looking at neck rotation. My
Absolutely.
tell me more. Yeah, yeah. So I'd like
Absolutely.
to give you two stories. One
Sure.
is a patient with 15 years of pain, and she said it started in my foot, and then it went up, and she did that maneuver. Okay, and
Mhm.
she had a very compressed, malaligned mandible. I have a gorgeous external approach to the TMJ. And oftentimes patients get up from the jaw work and they say, wow, my whole body feels different.
Mm.
not unusual for them to say that. And I don't fully understand, but
Yeah.
it's interesting. But anyway, so with my whole body approach, I screened her whole body. And yes, there was a micromotion impairment in the foot and ankle.
Mhm.
I corrected it. I went all the way up the body, and the other ones released, including her jaw.
So meaning that the foot released the jaw?
That is correct. Yeah. The other interesting thing about her presentation is she said, for 15 years, I've been telling every clinician that I encounter, and they say things like, that doesn't make any sense. And I looked at her and I said, that makes perfect sense.
I love it.
Other one, I will never forget. We stay in touch. He's a French osteopath, and he was in my course in San Francisco, I don't know, 10 years ago. I don't know. And he wanted to trade work after the class. So we got together and we traded. And I asked him, I said, did you take my course to learn the material or for me to work on you? And he said, for me to work on you, for you to work on me. He
Right.
said, you work like I do, but I can't find anybody back home. I said, okay. So I screened his whole body. I said, I don't find anything except two things. Number one, you have hypermobility syndrome.
Mhm.
All your joints are a little bit lax. And number two, your atlas at the atlantoaxial joint is hyperextended. He affirmed he knew both of those. He said, yeah. He said, when I was 10, I did a face plant off a bicycle. So with much intimidation, much caution, I mobilized the atlantoaxial joint in the sagittal plane. Most people treat it for rotation, which doesn't correct an impairment. Weirdest joint in the body. When it glides, it climbs up. The dens is shaped like a thumb. So first it glides up, then it glides back.
Mhm.
It ascends. There's no other joint like that in the human body. So part of the treatment is traction, and the other is positioning it in what the position of ease.
Okay.
Very slight flexion with subtle glide, and then traction. But the traction has to be very specific. That being said, I treated him, and I don't know what motivated me. I checked the rest of his body again. Every joint was solid.
Really?
He wrote me, he said, my whole life is different. He said, my emotional, my psychological outlook, my optimism, everything is different. And, I can only come up with theories.
Yeah.
Never made that promise to anybody.
Yeah.
I don't know if I'll ever see another one of those in my life. He probably had some anatomical predisposition to lowered circulation to the anterior aspect of the cord, but that's as far as I'll go with that.
Yeah.
I've treated one or two people with POTS, and they have an atlas issue similarly, and I treat it and they get up like, oh my God. They check their heart rate on their watch, they have
Yeah.
a watch and they're like, wow, I can sit. Now I can walk. Wow, this is different. So there are phenomenal things that can happen, but mostly on bottom up, because the bottom dysfunction creates something to the upper body, but once in a while it is top down. And so, the whole body approach is just predicated on treat the most apparent restrictions wherever you find them. I would always tend to start bottom up. That's just what
Mhm.
works for me for most of the people. And there's people that'll tell you it's always top down, and
Well,
you know,
I would go based on the mechanism of injury. If it's someone diving and hits their head, I think I would start at the head first. If
okay,
someone's injuring the foot, then I would start at the foot and work up. So that's why I always like, if we know what the
right,
mechanism of injury is,
right,
when this pain started, I like to kind of figure out what were the forces imparted on that body during that experience. And
yes,
and then work there. So
And the body reveals, so you find it.
yes,
Yeah,
yeah,
You know, in it was about 1992, 1990, right around that area, that era, that period of time, when I started to delve even deeper into developing a whole body of work. I wanted to be competent in every joint in the body. And so I would do a whole body assessment, and then I would treat the lowest denominator, and then
Mhm.
I would go and test the whole body.
Wow.
And
Lowest
that,
denominator meaning the joint that
let's
did.
say someone had a restriction in their subtalar joint,
Yeah,
okay,
yeah.
and that they had several others in the body. So
Uh-huh.
I would treat that, and I learned that lower body transverse plane rotations and saddle asymmetries and even frontal are typically compensated for at the atlas. Well, the atlas only carries a 10-pound head, you know, and it rotates so easily and so much. It can rotate 45 left, 45 right. So that's a great place to compensate. But then when the pelvis is asymmetrical, such that the sacrum is the focal point of greatest asymmetry. I'm not saying the sacrum moved inside the SI joint. I did not say that. Then interestingly, the compensation is in the mid sternum, T3, T4, and the corresponding rib on one side. And I had a hard time struggling, like, why would the body do that? That takes a lot of energy. And then someone recently pointed out, well, you know, in walking, if the pelvis rotates left, where does the rib cage go? It goes right.
Yeah.
And that's, you know, and so it made perfect sense to me then. It took me quite a while to
Yeah.
connect the dot.
There's always a reason why, right? If
Right.
we
The
can
body, yeah,
stay
yeah,
curious with it, we'll eventually get it. So Jerry, this has been
right.
fascinating conversation. And I know we can talk for hours, so we'll definitely have you back on in another episode so we can dive in deeper. But you're going to be joining us for the Birth Healing Summit this year, and we're going to be talking more about different patterns that you're finding in the pelvis. I've been finding some myself, and I'm curious if they are correlated or not.
Nice.
So
Nice.
yeah,
I just
yes,
want to add
yeah,
that pregnancy and birth, as of course we know, induces stresses on the body, but so does the postpartum period. Holding baby in one arm repeatedly, getting up in the middle of the night, not being really cognizant of your posture or your movement or
yeah.
what have you, you know, all that stuff adds up, but it's a whole body phenomenon. It is not a problem of, I just need to treat her pelvis.
Amen. Amen. Sing it, Jerry, sing it. Yeah, it's, you know, yes, we need to, the pregnancy affects the whole body, how they're using their body, all
And
that.
I'll add that when you want to downtrain a hypertonic pelvic floor, look outside of the pelvis.
Ooh, okay. Let's hold that thought and let's dive into
Okay,
that more in the summit interview, okay?
good, very good.
Okay, we'll do that. Well, thank you everybody for listening in. And please check out Jerry's courses on his website, heschinstitute.com. And we'll put a link below in the show notes for you to check that out, okay? So there are fabulous courses. I highly recommend them. So, all right. Thank you, Jerry, for your time here. Thank you, everybody, for listening in. And here is to more smoother births and faster recoveries. Take care, everybody. Bye-bye.
Bye.
Today's podcast was brought to you by the Institute for Birth Healing. To discover more, visit instituteforbirthhealing.com. To claim $50 off of any online course, use coupon code podcast50 at checkout. Till next time, I'm Lynn Schulte, founder of the Institute for Birth Healing.